And good afternoon, everybody. So, this session is Essential Retina Insights for the Comprehensive Ophthalmologist. And this will delve into some common situations as well as common diseases which general ophthalmologist should either handle or refer. And this, most of the talks will delve into those. So,
So,
yeah, peripheral retinal degeneration to treat or not.
Dr. Shishir, who is a retinal surgeon in Amita Eye Care, Tiruvalla, he'll be talking about peripheral retinal degeneration to treat or not.
So, good morning, everybody, and thank you, KSOS, for this opportunity. So, peripheral retinal degenerations is very commonly seen, encountered in our clinics, as most of the patients they come with complaints of flashes, floaters, and all those things. So, I thought, why not we have this topic? So, what is the importance of these peripheral degenerations? The annual incidence of reg RD is 10 to 18 in 1 million population. So 20 to 40% have had cataract surgery, and more than half of the reg RD occurs in these myopic eyes. So what is peripheral retinal degeneration? It's a deterioration and loss of retinal tissue leading to thinning in the retinal periphery. So patients who undergo refractive surgery to reduce myopia should be informed that they remain the risk of reg RD despite reduction of their refractive power. So how do you classify these? Just a brief small slide: intraretinal degeneration, vitreoretinal degeneration, and chorioretinal degeneration. And the most common what we encounter is a lattice degeneration with the incidence of 6 to 8% even in the normal population, and most 33 to 40% are seen in myopes, and 30% RD is associated with lattice degeneration. And around 30 to 80% can have horseshoe tear developing at the edges of the lattice, especially when a PVD has got induced, and 1% are at risk of having a RD at 10 years. So they require a long-term follow-up. Ideally, every 6 monthly to a yearly follow-up is required, especially when you detect lattice degeneration. So this is an example of 45 male who had a lattice degeneration. So we kept him on follow, but he came after 2 years with this retinal detachment where there was a hole which developed at the edge of the lattice. And then this is post-surgery, how this fundus looks like. So this is what the other eye. So when you have an RD in the other eye, it's important to treat the lattice in the other eye. And the other eye we did a barrage laser for the lattice which was seen superiorly. That also had a small atrophic hole at the edge of the lattice. So next is the snail track degeneration. The prevalence is around 10% in general population. Here myopes are again frequently affected, approximately 40%, and they have the same size, shape, orientation as a lattice. They can be at the edge of a blood vessel, or they're usually a little more longer than the lattice. And some of them, they can be associated with holes. So here another patient who came with a large snail track degeneration with large holes with a cuff of subretinal fluid, and then we proceeded and did a barrage laser for the same for that. So any lattice presenting with a hole or subretinal fluid is an indication to be treated with barrage laser. So atrophic holes, they are also small holes due to degenerative changes in the peripheral retina due to loss of tissue. So they're not associated with vitreoretinal traction, but they can have an association with lattice in 43% of the patients. So they need to be again closely followed up, and they ideally don't require treatment unless the patient is symptomatic, having flashes, floaters, and all those things, or if they have a retinal detachment or family history of retinal detachment. So snowflake degeneration is another. These are basically small cholesterol deposits which occur at the edge of the peripheral retina. And then white without pressure is also commonly encountered. That is a blanching of the retina without any applying any indentation. And most of these don't need any treatment at all. They just need to be observed and followed up ideally every 6 monthly or yearly. A giant retinal tear is supposed to be caused due to a presence of a white without pressure. And this is basically a tear occurring more than 2 to 3 clock hours in the retina. So what causes a retinal detachment in an eye with peripheral retinal degeneration? So the main thing is the PVD, or a posterior vitreous detachment. So we know that the most adherent part of the PVD, especially in the peripheral retina, and when the PVD occurs, the peripheral retina tends to tear, and that causes a horseshoe tear. And then if you don't treat it and you keep it a little more long, and the subretinal fluid starts to develop, and that causes a retinal detachment. So it's the interaction between vitreoretinal traction and the fragile retina in the periphery which causes a retinal tear, and tears occurs at abnormal sites of vitreoretinal adhesion. So most of patients, some of them they come with acute symptomatic PVD. They can have acute onset of flashes or floaters, and this acute PVD can cause vitreous hemorrhage, retinal tears, and even retinal detachment. So if they come with a symptomatic PVD, you need a repeat retinal examination after 4 to 6 weeks, as a process of PVD may be just progressing. Initially, it may just have detached from the posterior part, and then you can progress and detach from the periphery. So you need to keep following up this patients, especially when they come with a sudden complaint of flashes or floaters due to the PVD. So these are horseshoe tears which develop once the PVD has occurred, and due to the presence of in the periphery, they tend to tear and cause these become symptomatic. And then once the horseshoe tear starts to flap because of the movement of the eye, that's when the patient has flashes. So flap tears are a site of persistent retinal attraction, and these need to be treated. So there's an example of a 50-year-old male who presented with complaints of floaters suddenly while he was driving, and then once he came for an examination, we saw that he had developed a PVD and a horseshoe tear in the superior part. Did a barrage laser for him, and a post barrage, this is the healing which you can see 1 month after the treatment with laser, and his floaters had also reduced. So acute onset of vitreous hemorrhage in a non-diabetic eye or a patient who doesn't have any systemic, this is also one of the reasons where you can have vitreous hemorrhage. So peripheral retinal degeneration again has been classified: those which predispose to RD, which are lattice, snail track, retinoschisis, white without pressure, retinal holes and tears, meridional fold; and those who do not predispose to RD, snowflake, paving stone, honeycomb, white with pressure, and some meridional, commonly meridional folds. So if you come to the AAO treatment guidelines, these are all based on the Western data and doesn't consider follow up. So if we look at the guidelines, we do need uniform guidelines to treat peripheral retinal degenerations. So as of now, there are no clear recommendations treating peripheral retinal degeneration, and there is different opinions which has created doubt and confusion. And in this era of medical legal issues, we need to have some guidelines. So as I said, AAO guidelines are based on Western data and they do not consider difficult clinical situations. So suggested approach, step 1, what is the lesion? You need to know what the lesion is. What are the vitreous changes surrounding the lesion? Now, even peripheral OCTs are available to take, to get the depth of the retina as well as the vitreous changes around the lesion. And what are the risk factors in that patient which can predispose to development of RD? So these are the recommendations. All symptomatic and asymptomatic HSTs should be treated promptly. All symptomatic lattice without retinal holes and atrophic holes, treatment is usually recommended. All asymptomatic lattice without retinal holes, pigmented lattice, and atrophic holes can be observed. And eyes with atrophic holes or lattice, where the fellow eye has already developed RD, treatment should be done. It can be considered, but ideally should be done in our Indian population. So, take home message: patients undergoing refractive surgery, thorough retinal examination to look for peripheral lesions, prophylactic barrage laser predisposing should be done to predisposing degenerative retinal lesions at least 2 weeks before surgery, and retinal examination should be done at regular intervals, and development or progression of PVD, retinal tears, retinal detachment, and macular pathologies should be looked out for, and such patients should be followed up very regularly. Thank you.
Thank you, Dr. Shishir, for explaining things which is not commonly explained. It's important also to know that when you explain, okay, we'll do laser, it will prevent RD. So the patient has this belief that the RD will never develop in a laser done eye. Please understand, laser do give good protection, but we have seen retinal detachment developing in patients despite this laser barrage. One, the edge of the laser barrage might give way. Two, new lesion can start happening on the other part of the fundus. So I think while explaining to the patient about a protection from RD, you should also explain that you need to come for follow-up and re-evaluate later on in his life as well, or when a new symptoms develop. Thank you, Dr. Shishir. And now I call upon Dr. Anju on OCT in retinal pathology, what a general ophthalmologist should know.
Good morning to one and all present here. So I am going to talk about OCT, what a general ophthalmologist should know. So basically I'll be discussing with all these topics. And all these topics, first is introduction. So it is a non-invasive, non-contact transpupillary imaging system which provides high-resolution cross-sectional image. Is used as a principle of low coherence interferometry. So next is scanning protocol. So I'm not going into detail of all of this. So we use time domains, which is an old one which cannot picture 3D images. Next is frequency domains, web source. Commonly used one is spectralis OCT, which was introduced in 2006 based on HRA2. It has incorporated two imaging techniques, that is confocal scanning laser ophthalmoscopy, which is commonly used for octa and autofluorescence. Next is confocal imaging creates transversal image of the retina corresponding to on-force phase of OCT. It utilizes infrared CSLO scans for automatic motion tracking. So next I'll be going into the detail of OCT scan protocols, in which macular scan, thickness scan will be dealt in detail. So these, as we all know, these are the layers of the retinal layers seen in OCT macula. We'll be going in detail with this. So first one is line scan ophthalmoscope. In this only the thickness is measured. Next is ETDRS. In ETDRS, we'll be measuring the thickness from the ILM to the RP. It consists of 3 circles, outer, inner and innermost circles. Next one is cross hairline image, which shows a black and white or color-coded images which represents the macula taken from the horizontal direction from the temporal to the nasal. So next is raster scan, which is a selective scanning profile. It's usually taken at the angle of 30 degrees. So first question, when we see an OCT, we have to find out which eye is this. So how do we know which eye is this? So this is an OCT image of right eye. How do we know that? Because of the thick RNFL hyperreflective band exiting through the retina through the ONH. So next is OCT analysis and interpretation. So we have to know the basic international nomenclature for OCT. We use these terminologies. First is band, which shows the 3D structure of the retinal layers anatomically. Next is zones, region on OCT whose anatomical correlation was not clearly delineated. Next is RP-Brux membrane complex, one of the layers described as zone, as they are inseparable owing to the interdigitation of the cellular structure or tissue. So next is going into the interpretation. It is normal OCT interpretation with all these layers. First is pre-retina. Is a vitreous anterior to the retina, non-reflective dark spot on the OCT. We can see faint dots as noise formed due to electronic aberrations. Next is vitreoretinal interface. Is well defined due to the contrast between the non-reflective vitreous and the backscattering of retina. The contents vitreous overlying the ILM is called as a posterior vitreous phase. Next is epiretina. Epiretina is anterior surface of the retina, in which commonly seen as epiretinal membrane. Next we are going into the retina proper. This is anterior boundary from the hyperreflective band of ILM to the posteriorly bounded posteriorly by the RP layer. Next we have one more entity called as outer retina, which is very commonly used nowadays, which consists of an ELM layer, ISOS junction, RP-Brux membrane with myoid zone, ellipsoid zone and interdigitation zones. Next is choroid. Choroid is commonly seen within EDI OCT. So next is what is the foveal cut we see. So foveal cut is the area where the outer plexiform and the RNFL meets. So we'll be dealing this OCT into a qualitative analysis and a quantitative analysis. Based on the qualitative analysis, first is morphological study, in which we'll be seeing the overlying retinal changes with retinal outline. In this, we'll be dealing with the major regions, that is pre-retinal area, epiretinal, intraretinal and subretinal. So next is the reflectivity studies. Based on these terminologies only, we interpret the OCT, like hyperreflective, which appears as a white in color, hypo is dark in color, and next is shadowing. So these are the pictures showing hyperreflective dots here, hyporeflective cavitatory lesions here. This is a shadowing and this is reverse shadowing. So these are the common reflective structures. You can take a picture if you want. So these are the abnormal pathology. If we know the normal reflective structures only, we will be able to find out which are the abnormal reflective structures. So this is high reflective structures in each layers, and this is medium reflective structures and low reflective structures, that is hyporeflective structures. So next is the shadowing. In this also we'll be seeing superficial shadowing, interretinal shadowing, deep shadowing, each and everything. So next we'll be dealing with the quantitative analysis. In this quantitative analysis only we'll be dealing with the retinal thickness, based on which we'll be seeing whether the treatment has to be given for the diabetic retinopathy based on the study grid, and we'll be depicting the thickness based on it. So next is the retinal maps. In this color maps are used for each and every layer. A single color is used. So when you got an OCT, we have found out which protocol it is used, which eye we have identified. So now what do we do? So first determine the scan quality. Next, rate the overall scan picture profile and evaluate the foveal profile. Next, identify the foveal cut and carry out the structural assessment. Structural assessment will be each and every structure, like from pre-retina to the epiretina. So these are the common terminologies used. I'm not going into the detail of this. So next is clinical cases. So first is vitreous and vitreomacular interface pathology. This is a vitreous hemorrhage. We'll be seeing a subhyaloid hemorrhage. In OCT, we'll be seeing as a shadowing of the inner layers from the hemorrhage with the PVD. Next is asteroid hyalosis seen in a B scan, with seen in a multiple hyperreflective spots seen in the vitreous cavity. Next is vitreous cells seen as dot-like hyperreflective materials. Next is PVD. This is the first one, thin hyperreflective layer. Next will be CME with PVD VMT. Next is complete PVD. This is epiretinal membrane seen as a corrugated surface adherent to the ILM. Next is vitreomacular traction. First is VMA within the 3 mm of the radial fovea. Next is the VMT. In VMA, there will not be any retinal morphological changes. In VMT, there will be retinal morphological changes. Next will be full thickness macular hole. So next is intraretinal. I'll run with this. And first one is macular edema. Second is the stages of macular holes. And in hard exudates, we'll be seeing hyperreflective spots with back shadowing. That is how we identify it as hard exudate. Next is cotton wool spot corresponding with hyperreflective layers. Next is intraretinal hemorrhages. This is retinal degeneration. The next is inner and outer retinal atrophies, retinoschisis, HCQ toxicity, early photoreceptor and outer retinal damage with a spaceship sign. Next is subretinal, is ARMD, drosenoid PEDs, wet ARMD showing intraretinal edema, exudates and subretinal hemorrhages with SRF, global geographic atrophy, CSR, PEDs with drusen's, serous PED and fibrovascular PED. In fibrovascular PED, we'll have to go with an octa. Neovascularization showing intraretinal fluid, subretinal fluid and tractional membrane. The outer retinal tubulations, retinal detachment. So these are the common newer findings which is discussed. You can take a picture if you want. These are advantages. Non-invasive, non-contact, more repeatable for the patient. So limitations are, and there is media opacities and artifacts. So I'm winding up with my session with this. Thank you.
Thank you, Dr. Anju, for that quick rundown on OCTs. So next we have Dr. Shane Matthew, who's a senior vitreoretinal consultant at Chaitanya Eye Hospital, Tiruvalla. He'll be talking to us on current approach to retinal vein occlusions.
Good afternoon to all. I think it's a repetition of the same talk in the same conference. I would like to reduce it or probably simplify it further. So what makes retinal venous occlusion a little different is because I call them as the Tandoni of retinal diseases, because they don't follow any rules. You keep injecting, the patient may do well. Keep injecting, the patient may not do well. A BRVO may need more injections. A CRVO may not need this many injections. So there are no rules in this. But let's see what rules I do practice in my clinic and how I have changed managing these diseases over the past 15 years because we have lot new armamentarium with us to make it a much better disease to treat with. I still remember while I was an MBBS student and I attended one of this conference with my mom and one of the senior vitreoretinal surgeons saying, if you have a CRVO, send it to your enemy. And that is how we are, because it is about sudden loss of vision, transient blurring of vision, or rarely retrobulbar pulsations. The take-home message is, please look into the visual acuity of the patient, check for RAPD. Maybe that's a first sign of conversion to an ischemic venous occlusion. Look into the intraocular pressure as well as the location of the occlusion. It's very easy to diagnose a retinal venous occlusion. It is right there. But please look into the location. Hemicentral retinal vein occlusion, like this one here, follows the same pattern as that of a central retinal venous occlusion. So the follow-up should be like as that of a central venous occlusion. Sometimes the occlusion will be at the far periphery and you might find on a cursory fundus evaluation. You don't need to treat this patient at all. If it develops a neovascularization, then we need to treat it with laser. This is an impending RVO. We need to know this disease. It's called a venous stasis retinopathy, a lighter version of a furious RVO. But we need to know, not for the eye, but a systemic comorbidity might be lingering around in this patient. This patient had acute myeloid leukemia, which was found out after having seen this fundus picture. Sometimes a normal looking fundus. This is when actually multicolor imaging comes into play. Nearly normal looking fundus. Multicolor images clearly shows me the sclerosed veins in the inferior quadrant, telling me that this patient had an old RVO. So it's very important to do a systemic workup because most of these disorders are associated with a lot of systemic diseases. You can't write up all this investigation for every patient. So you need to divide the patients into two. Patients with young RVOs, patients with old RVOs. Less than 50, young RVO, more than 50, older RVO. And bilateral disease, I put it in the younger forms because better prognosis, uncommon etiologies are associated with young RVOs, lesser treatment burden, and better reparative process. Whereas old patients with RVO, think about an asymptomatic cerebrovascular and cardiovascular disease associated with it. So please send it to an internist for risk analysis for stroke and cardiac events. All patients should undergo a routine blood, RBS, lipid profile, and BP monitoring, probably a 24-hour BP monitoring. But I would like to draw your attention to triglyceride levels. Studies have clearly shown increased triglyceride level has a 10-fold increase in CRVO occurrence. Hemoglobin, increase in hemoglobin. This part of the world, this is relatively common now. A subclinical hypothyroidism, normal T3, T4 values, but a little elevated TSH level. Normally we would miss this. And also hyperhomocystinemia. So please look into these as well while you deal with the case of an RVO. It's important to stratify or divide the RVOs into a less severe variety called a non-ischemic variety, better vision, no RAPD, to a more severe form, an ischemic RVO with worse vision, RAPD, and ERG B-wave abnormalities. So why is it important to risk stratify them? It's because we need to see all these patients would need multiple treatment sessions, long duration of follow-up. So we need to reduce the treatment session and also reduce the follow-up. How do we do that? That is only by risk stratifying them. And one of the most important things is to look for the ischemic conversion. In that, ideally, initial stage of the disease, you can't do an angiogram, but once the edema has subsided, maybe after a couple of injections, or in the natural course, after a couple of months, or maybe 1 or 2 months, or even 3 months, you can do a wide field angiogram. Wide field angiogram or ultra wide field angiogram helps us in showing us the peripheral capillary non-perfusion area, which is a biomarker for worsening disease. Now, studies have shown that the ischemic index is nothing but the area of capillary dropout to the area of perfusion. And if that is less than 10, these are the patients who will do well with macular edema treatment. And if you see more than 75 disc diameters of capillary non-perfusion, so 75 dd corresponds to, if you divide this fundus picture into 4 equal halves, 1/2. If you see more than that, you know that there is a good chance of neovascular development. So it is a good idea to do an angiogram. Probably one area where I would not hesitate in doing an angiogram is in this. After 3 to 4 months of post-CRVU, I would definitely do an angiogram to get these many information so that I can follow up on a personalized basis. So the next thing you look for is a collateral formation. Whenever the patient comes into your clinic, look for a collateral. So this is a BRVO with the last picture showing a collateral there. So when you see a collateral, now I know the repair is starting. The disease is slowing down and may need lesser follow-up visits and injections. So sometimes you see a retinal capillary macroaneurysm like this here, and that may be the source of macular edema in these cases. A focal laser to that may save the day for treating macular edema. OCT angiogram helps us in finding out macular ischemia and also a mid-peripheral ischemia. But I would say OCTA cannot replace a ultra-wide field fundus fluorescent angiography because you cannot get images of that far periphery as for now in commercially available machines. And macular edema is the main culprit, what we treat normally. And OCT is by far the best investigative modality in detecting macular edema in this eyes. But anyway, in the start of the talk, I said it's a tandoni. So prognostic biomarkers has got little role here, but some of the biomarkers. So initially you do an OCT, you need to know whether there's macular edema or not, you start treating. But how to prognosticate, how to follow up, you repeat an OCT by around 3 to 4 months after you give injections. And then when you see that there is a residual central retinal thickness, if there is increase in cyst size or percentage of drill, then you know that this patient is not going to do well. And also ischemic indices such as hyperreflective inner retinal layers, PAM or a drill, these are all poor prognostic biomarkers, and these are the patients we may stop injecting at that point and then probably re-inject only if the visual acuity is decreasing further because of edema. So when not to stop treating, if the visual acuity is increasing, continue giving monthly injection because that is the best. But here is the news. Retained study, 4-year data told us that 50% of the eyes still need a treatment after 4 years of continued treatment. So we are looking at a very, very, very chronic disease. Now, once you decide to stop your anti-VEGF, look at the blue letters there. Once you stop anti-VEGF, that is the time to sit back and follow up the patient closely because of the VEGF upsurge, patient can have neovascularization. So once you stop treating, kindly follow the patient closely for 3 to 4 months for that. So there are ways, I'm just quickly going through. So this is one important point. See, look for reocclusion. So once you need to understand that once there is an RVO, there is also a chance that a re-RVO can occur in the same patient. Look at this patient. Initially, the patient had an RVO. We treated well, middle slide, showing that things are settling down. 4 months later, patient has a reocclusion. So once you see a reocclusion, then what do? That is the time when you have to revisit the systemic status of the patient. And the patient may not regain a reocclusion vision, and there is a high risk for neovascularization. Neovascularization, the standard treatment is retinal photocoagulation, even though anti-VEGF has a role and can continue, but I would still feel the treatment of choice is peripheral retinal laser photocoagulation. And neovascularization, the risk is more in the first year, so kindly follow this patient up closely during the first year. So that's where we are at the end of the talk, and a close follow-up with a risk stratification can reduce the number of injections and also reduce the number of follow-up. Here we have a chronic disease, so please take care looking into the selective systemic evaluation and also trying to find out what systemic disease the patient has. Thank you very much for your patient listening.
Thank you, sir, for that very updated and interesting talk. So in warrant of time, we'll keep discussions towards the end. So next we have Dr. Risha, who's a cataract surgeon, senior consultant, medical retina and UV at Little Flower Hospital, Angamali, and she'll talk to us on common inflammatory disorders of the posterior segment. Over to you, Dr. Risha.
Thank you, Dr. Shishir. Before I start my talk on inflammations of posterior segment, I will show you 2 slides. See, this young girl presented with a severe occlusive vasculitis bilateral 1 week after a dengue fever attack. So we were like, dengue usually doesn't cause this much of occlusive vasculitis. So we were searching for a rheumatology cause in this girl. And after 2 weeks, this was the picture. Both eyes, she developed vitreous hemorrhage. She had undergone immediate VR surgery. Her all rheumatology workup came to be negative. That was a case of post-dengue occlusive vasculitis. So timely diagnosis is very important. So can we treat all posterior segment inflammations with systemic steroids? No, all these posterior segment, posterior uveitis looks very much similar, but all these have different clinical diagnosis, and most of them are infectious also. So I'll give you 10 practical tips for the management of posterior segment inflammation. The first and most important tip is a good history taking. This 23-year-old 7-month pregnant lady presented with choroiditis with inflammation. She gave a history of pulmonary TB for her mother 1 year before, and also for her sister treated for 6 months. So that was a case of choroiditis due to tuberculosis. Her manto was high, ESR was also elevated. She was treated with ATT and lesion resolved completely. Another young engineering student presented with an intermediate uveitis like picture. So after all evaluation, all investigations came to be negative. So we started him on systemic steroids. See, after 1 week, the vitritis was worsening. So again and again we were asking for anything we were missing in the diagnosis. So he gave a history of IV drug abuse. So that was a case of endogenous endophthalmitis. And yet another forest officer presented with this lesion in one eye, and we were keep on evaluating and couldn't find out any positive history, any positive investigations. Then patient was asking me, doctor, is it related to any of my dushilams? So immediately I sent the investigations, HIV, VDRL, TPH, and VDRL and TPH came to be positive. So that was a case of syphilis. And after starting on CP and steroids, the lesion resolved completely, and we could regain the vision. And the second tip is good physical, head to foot physical examination. See, this patient presented with a bilateral hypopyon uveitis with vitritis and vasculitis. And on evaluation, he had mouth ulcers, so it's a case of Behçet. Next, bilateral posterior uveitis with disc leak and pinpoint leaks in FFA. Patient may or may not have these systemic findings like alopecia and vitiligo in a case of VKH syndrome. See this again, a young lady presented with bilateral occlusive vasculitis, and patient had this malar rash. So it's a case of SLE retinopathy. And the third tip is good ocular examination. See, this patient was treated as intermediate uveitis initially. See, on indirect ophthalmoscopy initially, an active toxos lesion is there. So it's a case of toxo-uveitis. Again, examination of the other eye is also very important. This patient presented with granulomatous uveitis and fluid detachments. The other eye, old history of trauma, thysical eye. So that was a case of sympathetic ophthalmia. And the fourth tip is always exclude an infectious cause. See, these are all infectious examples of infectious uveitis. First one is ARN, which needs immediate treatment, and second is toxo-retinochoroiditis, and third one was DUSN. And of course, tuberculosis, always rule out tuberculosis in all uveitis because it can have protein manifestations. And whenever you are not able to find out anything underneath because of severe vitritis, go for PCR so that you won't miss any viral retinitis. And the most important thing is, if the inflammation is not responding as you expect to your steroids or other immunomodulatory therapy, again ensure that an infectious cause is not missed. And do not miss an active inflammation. In this case, no, patient BKH patient has some bilateral pan uveitis. FFA shows disc leak and pinpoint leaks, and EDI OCT helps in these conditions. Macula choroidal thickness reduces as the lesion heals. And this picture shows a healed serpiginous lesion, but fundus autofluorescence shows there is still active lesion is there and needs more treatment. And do not forget about masquerades with obtaining a biopsy. This child presented with hypopyon uveitis not responding to topical steroids, and AC tabs showed retinoblastoma cells. Again, these two cases mimic very much like posterior scleritis, but look carefully, there is no signs of much inflammation. And first picture was CA breast with choroidal metastasis, and the second picture, patient had CA lung with a choroidal lesion. And if indicated, do not hesitate to start steroid sparing agents. Even though steroids are the mainstay of treatment, if patient needs long-term immunosuppression after a high-dose corticosteroid pulse therapy, you may have to go for immunosuppressive agents or biologicals, and consider sustained release steroids like Ozurdex if patient has CME complicated to intermediate or posterior uveitis. And think about other non-uveitic conditions also. Like this patient was treated as toxo-uveitis. She was already on Bactrim DS and steroids, but no improvement. CFFA shows this pinpoint leaks. This was a case of CSR with fibrin. So immediately we stopped steroids and gave laser. And do not forget about complications like toxo scar can have associated CNVM, and OCT could pick up. And always discuss with your friends. And these are the 10 commandments: proper history taking, physical examination, complete ocular examination, exclude infectious cause, do not miss active inflammation, do not forget about masquerades. If indicated, do not hesitate to start steroid sparing agents, consider sustained release steroids, think about non-uveitic conditions, and discuss with your friends. Thank you.
Thank you, Dr. Risha, for that superb talk encompassing all the posterior uveitis conditions. Now, next we have Dr. Prithvi Chandrakant, who's a vitreoretinal surgeon at Dr. Chandrakant Netralia Kozhikode, and he'll be talking to us on diabetic retinopathy essentials for the general ophthalmologist. Over to you, Dr. Prithvi.
At the outset, I would like to thank Dr. Shishir for this opportunity, and KSOS also. I'll be talking about diabetic retinopathy essentials. Just for a introduction, it's a chronic progressive sight-threatening disease of the retinal microvascular associated with prolonged hypoglycemia and associated with other conditions such as hypertension. Just a small brief on epidemiology. So type 1, that's insulin dependent, is 70%, non-insulin dependent and is 39%, and type 2 with insulin is 70%. The prevalence, as you can see, the type 2 is almost 90% of diabetic patients, and the most common cause of legal blindness between ages of 20 and 70 years. The risk factors that we need to know is about the duration of diabetes, poor control of diabetes, hypertension, nephropathy, obesity and hyperlipidemia, smoking and pregnancy. So duration of diabetes is the best predictor of diabetic retinopathy, and a patient diagnosed with diabetes mellitus before the age of 30 years, the incidence of DR after 10 years is 50% and around 90% in 30 years. And after 20 years of diabetes, nearly 99% of patients with the type 1 and 60% with type 2. Poor glycemic control. As you can see, the diabetes control and complication trial have showed that the risk of developing retinopathy is 76% reduction in intensive control and slowed the progression of retinopathy by 54%. The UKPDS also gives a similar consensus, and the target HbA1c should be between 6.5 to 7%. So pregnancy is sometimes associated with the rapid progression of diabetic retinopathy, and the key factors are greater pre-pregnancy severity of retinopathy, poor pre-pregnancy control of diabetes, and control exerted too rapidly during the early stage of pregnancy, and development of pre-eclampsia and fluid balance. So the hypertension, and it's given the ABC trial that target BP should be less than 140 by 80, and the Euclid gives us showed the lower rate of development of retinopathy in diabetes taking lisinopril for antihypertensive medications. In nephropathy, if severe, is associated with worsening of DR, and conversely, treatment of renal disease may be associated with improvement of retinopathy. Other factors are smoking, male gender, hyperlipidemia, cataract surgery, obesity, anemia, carotid artery occlusion disease, and questionable about alcohol. Basically, what is happening there is the microvascular leakage because of loss of pericytes, which results in distension of weak capillary walls and producing microaneurysms. Also, the blood retinal barrier breaks down, causing plasma concentrations to leak, and ultimately causes retinal edema and hard exudates. The basement membrane thickening happens. The endothelial cell damages, deformed RBCs, platelets thickness, and aggregation is the other factors. Finally, what happens is vascular endothelial growth factor is produced by the hypoxic retina, and which stimulates the VEGF, the growth of shunts and new vessels. This is a small picture showing the same. So what happens in this is exactly how it looks in a defective patient's vision. So this is a small flow chart showing the same. So classification of DR is non-proliferative, proliferative, and the second thing is the clinical significant macular edema, CSME. So this is a classification from the International Classification of Diabetic Retinopathy and Diabetic Macular Edema. And what about diabetic vitropathy? That is vitreous structures, which the diabetes induces changes of posterior vitreous, cortical vitreous, and it happens due to glycation of the vitreous and precocious synthesis. These are other classifications. Just a brief video of what are the signs of diabetic retinopathy. As you can see, the small dots are microaneurysms and dot blot hemorrhages. You can see the dot blot hemorrhages here. See the hard exudates. This is the cotton wool spots. So this is our these are the hard exudates, cotton wool spots. And you can see over here the focal diabetic maculopathy, circular hard exudate with a small microaneurysm over here. The diffuse diabetic maculopathy, venous changes, that is looping, venous changes, beading, severe segmentations, and then the ETDRS CSME protocol, in which you can see that the optic disc diameter, that is 1 disc diameter. So you see the fovea, 1 disc diameter around the fovea, and the 500 microns, that is where the retinal thickening happens. So then it is called a CSME. What if there is hard exudates? That with the thickening is called CSME. This is the second classification. And the retinal thickening, which is almost 1 disc area, part of which is lying within the 1 disc diameter, is called. So this is how the IRMA looks, intraretinal microvascular abnormality. And this is proliferated diabetic retinopathy, mostly characterized by neovascularization of the disc, and elsewhere the mild form and the severe form. with fibrosis over here, and finally the NVI, rubeosis iridis. Here you can see the new vessels elsewhere with fibrosis, and this is the laser marks. Finally, advanced diabetic eye disease with the tractional component, that is the tractional retinal detachment over here. You can see over here, which is completely over the disc. This is a vitreous hemorrhage. This is a tractional retinal detachment, hyperemic disc, swelling. So blindness due to DR could happen because mainly because of non-clearing vitreous hemorrhage, neovascular glaucoma, tractional retinal detachment, and macular ischemia. So how do we prevent these complications? By early institution of appropriate treatment, early detection of DR in asymptomatic treatable conditions, by routine fundus examination of all the diabetes and appropriate referral to the ophthalmologist. So what is the treatment protocol? Mild and moderate. It is more in terms of observation. So good metabolic condition control needs to be done, and it delays the progression, and control of associated hypertension, anemia, and renal failure. Severe and non-severe, very severe needs to be closely followed up. Can also plan on scattered PRP. CSME, so you take a OCT and find out what are the diabetic macular changes, and what are the biomarkers, and we can actually plan on injections. If it's more chronic, we can actually plan on something like a steroid implant like Ozurdex. And if it's a non-central involving, you can always plan on a focal laser. So proliferative diabetic retinopathy is more well handled by retinal laser photocoagulation. It converts the hypoxic retina into anoxic retina. This is again the referral to the ophthalmologist. Visual symptoms, anything which has any patient has a diminished visual acuity, seeing floaters, painful eye, can be referred. Fundus findings, macular edema, hard exudate, close to fovea, and proliferated DR with VH, moderate to severe and severe NPDR retinal detachment, and cataract obscuring the fundus view. So diabetic papillopathy can be unilateral and bilateral. It's a mild form of non-arteritic ION, and a painless mild decrease in visual acuity, and it improves with anti-VEGF and steroids. So a lot of other studies, landmark studies, the DCCT, which tells that the intensive treatment 10 times more effective than the conventional, and HbA1c should be monitored well. And then the UKPDS, again telling us the reduction of incidence and progression risk from smoking could be accounted for lower blood pressure. And the ETDRS, the classification that we have got, we are still using the same. The DRS, which gives us that the pan-retinal photocoagulation is efficient for us to manage PDR cases. Just a small brief on PRP techniques. We usually keep a 1 disc diameter away from the arcade vessels and the disc, and temporarily at least 3 disc diameters, and give a photocoagulation. Should have at least a 1 burn apart PRP lasers to be done, and can do it within 2 sessions or 3 sessions. I do it more in 3 sessions with at least 1,000 spots in a session. The first one to go is the inferior retina, and then the other parts. Avoid blood vessels and hemorrhages, and also the tractional components, the fibrous proliferations. Complication of lasers are vasovagal attack, reduced contrast and color, peripheral vision loss, decreased night vision, CDs, exudative RDs, and pre-retinal hemorrhage membranes. So indication for diabetic vitrectomy, any non-clearing VH, any tractional RD involving the macula, combined RDs, progressive vascular membranes, refractive DME with attached posterior hyaloid, macular tractions, opacified posterior hyaloid phase, and eyes with rubiosis and media opacities. All these cases can be taken up for vitrectomy. Again, OCD biomarkers, just want to say that these are all the positive ones and the negative ones. The positive biomarkers will give you a good prognosis. Negative ones won't give you much of a prognosis. So we'll have to explain to the patients looking at these biomarkers whether their vision is going to be improved or not. Again, the ones with better visual outcomes, you can also see if it's chronic, and if it's chronic, you can plan on other steroid implants. Thank you.
Thank you, Dr. Prithvi. So we have, I think, 2 minutes for discussion. Any questions from the audience?
So we have seen diabetic retinopathy, and in the era of anti-VEGF therapy, and in the era where people are undergoing pancreatic transplant for diabetic retinopathy, you actually see some of the patients you saw as severe NVDR presenting 1 year later with you might think, oh, is this the patient which we diagnosed diabetic retinopathy? So there is, I just want to pass on this message that there is something called a featureless retinopathy where retinopathy subsides, but underground it is capillary non-perfusion is increasing and things are going on. Especially after multiple intravitreal agents, you might come across this. So please look carefully for mild sclerosed vessels here and there to see whether ischemia is progressing or not. So this is the message which I just wanted to pass on. Featureless retinopathy.
One question to you, sir. How important is homocysteine, especially in retinal vascular occlusions?
Yeah, so that's a very hot topic now. Throughout the net you hear about glutathione. I'm sure everybody knows about it. Everywhere it's about glutathione now. So homocysteine is very important. Uh, Medical professionals like us, one study said that almost 80% of the medical professionals had hyperhomocystinemia. Now, why is it important? Hyperhomocystinemia is associated with thrombotic events, not only venous occlusions, but also cerebrovascular accidents as well as cardiac diseases. So, I think our concentration is going more from hyperlipidemia to all these things. Now, simple vitamin supplementation can take care of homocystinemia many a time. So that is the importance of doing that. Like vitamin B6, B12, and
Okay, if no more questions, we can just end the session. Thank you.